Hi, I'm Randall Oyer. I'm a medical oncologist. I'm the medical director of a community cancer program in Lancaster, Pennsylvania, which is part of the University of Pennsylvania. And I'm here as a member and representative of the Association of Community Cancer Centers. So starting with the patient voice in the back of my mind, we heard our patient yesterday, Mary Scroggins, tell us that we need to act on what we know. So what do we know about high-performance teams? I'd like to talk a little bit about what we know, and then I'd like to suggest some action based upon that. We know that high-performance teams save lives, influence patient experience, improve quality and safety, and reduce waste. We know that members of high-performance teams are less likely to turn over, experience less burnout, and have more resilience. So I would suggest that the optimal cancer care force is a high-performance team. So I'd like to highlight 5 domains that I think speak to the functionality we need from our teams. Dr. Carlson told us a little bit about this yesterday, and I'll be honest with you, what I know about teams, I learned from the work of John Cox and the ASCO team and the NCI ASCO project that was published, and Diane and others participated in that, and it was in the JOPI in November of 2016. So starting with a shared mental model. I want to just take that concept a little bit further and say, yes, we need to have a purpose for what our work is, but I think we need to be really specific. We all think, well, our shared mental model is that we're going to take good care of our patients, but we all have different ideas, we have competing priorities, and we need to be specific. We're going to take good care of this group of patients within this time frame, in this geographic location, and with a cost that they can afford. We need to be specific about what our mental model is, and we need to have measurements that we can stick to and keep ourselves on task to make sure we're doing what we promised to do. Secondly, Len Lichtenfeld yesterday said we need to use technology. Well, we need to know how to use technology. And I think that there's a concept of disciplinary diversity on a team. You have to have the right people on the team to accomplish what you want to accomplish. Yesterday, Linda Jacobs presented her survivorship clinic, and I was really struck by the number of degrees, the number of people, and the number of disciplines it took to run her clinic. She had a PhD, CRNP, an MD, MSHP, research scientist, BA, and MPH. And so there's this concept of meta-knowledge. You have to understand who on a team knows what. Everybody doesn't need to know the same thing. And we need to be open to additional team members. Sam Tekvorian told us about Penny. And Courtney and others have told us about the caregivers who need to be on the team as well. And I'm optimistic. I'm an oncologist. I think the EMR can be a team member as well if we make changes. Thirdly, effective communication. We need to be precise. We need to be accurate, and our communication needs to be on time. Our communication needs to transcend settings, and it needs to transcend disciplines. We need to be able to talk to each other. Fourth, we need to be trained in interfaces. It's the space between what we individually do where we often get stuck or fall down. We're very good at breaking things up and assigning different tasks to different experts. We're not so good at bringing this back together, reintegrating it. There's something called reorganization or neglect. What relay team would forget to train their people in handing off the baton? We all need to understand what the upstream and downstream interfaces are. And lastly, we need to be trained in systems management. At our organization, we use lean. We're all trained in lean. We learn how to look for waste and cut out waste. I think we need to recognize that in medicine, we have a problem of overuse, underuse, and misuse. So I would like to propose that we have 3 action items, what our patients are asking us for. One is that we reform health professions education. At the medical school, nursing school level, mentoring, and even consider retraining. Point number 1. Secondly, I think we need to have intentional partnerships with professional organizations regarding agendas for teaching, programming, didactic workshops, and demonstration projects, including NCCN, ASCO, ASTRO, ONS, ACCC, the Association of Oncology Social Workers, the American College of Healthcare Executives, the COC, and patient advisory groups. And lastly, I think that we need a research agenda on implementation science, working with ASCO, the NIH, NCI, PCORI, cooperative groups, and community, or rather CMMI, so that we go down the path of discovery together. So in closing, I think that this workshop can lead to the National Academy of Medicine suggesting a 10-year project for transforming us to high-performance teams. Thank you.